Welcome to a review of peripheral blood and bone marrow morphology, the malignant diseases that we see in pediatric hematology oncology. I'm Mark Fleming from the Department of Pathology at Boston Children's Hospital. So in order to understand hematopoietic classification, one really has to understand cell lineage markers. Hematopoietic cells are all characterized by the expression of CD45. Certain markers such as HLA-DR and CD34 are present both on immature lymphoid and myeloid lineages. TDT is present on immature lymphoid cells, and CD117 is present on immature myeloid cells. The B lymphoid markers are what I like to call the college years. These include CD19, CD20, CD21, and CD22. CD10, also known as the common ALL antigen or CALA, is present on different B cell subtypes. Surface immunoglobulin kappa and lambda light chains or surface immunoglobulin heavy chains are present on mature B cells, whereas cytoplasmic heavy chain can be present in immature B cells. The T lymphoid markers are mostly markers with CD numbers less than 10. They include CD1A, which is on immature T cells, CD2, CD3, CD5, and CD7, which are present on nearly all mature T cells, and CD4 and CD8, which define T lineage subsets. CD99, which is the same marker that's present on Ewing sarcoma, is also present in immature T cells. The NK cells are the 6s, 16 and 56. Myeloid markers are the core or the teenage years, CD13, CD14, and CD15. An important marker, an important other myeloid marker is CD33. CD64 and 65 define the monocytic lineage as well as CD14. Myeloperoxidase is positive in myeloid cells and is a myeloid leukemia defining marker, and lysozyme is also present. Historically, we also use histochemistry, which are enzymatic or chemical stains to define lineages. Lymphoblasts are block PAS positive in about 80% of cases of pediatric ALL. Myeloperoxidase, which can be done enzymatically, is typical of the monocytic lineage, and non-specific esterase can be seen in the monocytic lineage. I also want to remind you of the normal pattern of B and T cell maturation. B cell maturation B cells are on the top left side here. You can see that CD19 is our canonical B lineage marker, and CD45 is slightly dimmer in all B cells than in T cells. If one looks at B cell maturation on the CD19 versus CD45 plot, the most immature cells are down on the left, are on the left, and they mature up and then back over. If we look at a plot of CALA or CD10 versus CD20, which comes on later in B lineage differentiation, the most immature cells that are brightest for CD10 are positive for CD34, colored in yellow here. And maturation occurs up along the CD20 axis, and then once CD20 reaches its maximum, CD10 tends to turn off, such that the most mature B cells that express surface immunoglobulins are CD10 negative. CD5 and CD7 are two of the earliest T cell markers. They're present on most cells, whereas CD7 positive, CD5 negative cells are NK cells. CD2 and CD3 are present on T cells, where CD2 is present just on NK cells. And as I said before, CD4 and CD8 define T lineage subtypes. So I'm going to approach this using a case-based model where I'm going to talk about classes of diseases and then discuss important subgroups within those classes of diseases, using cases as a launching point. So the first child is a 6-year-old girl with trisomy 21 and cardiac anomalies, status post-repair, now with lethargy and pallor. She presents with a normal white count, but a low hemoglobin, a moderately decreased platelet count, but 87% blasts in the peripheral blood. These blasts are of variable size. They're relatively large compared to a normal lymphocyte, and yet they still have some of the chromatin qualities of a normal lymphocyte, it being sort of streaky and coarse in quality, and yet there are small nuclei. In addition, there's a scant amount of agranular cytoplasm. These are all features that are typical of lymphoblasts. By flow cytometry, these cells exhibit the typical phenotype of precursor B ALL, where they are dim or negative for CD45, they're positive for HLA-DR, they're positive for CD19, which is present on essentially all B cell leukemias, they're variable for CD20, they're positive for surface CD22, they're positive for the common ALL antigen CD10, they're negative for surface IG, and they're positive for TDT. In addition, by flow cytometry, as I said, we can see TDT positivity in these cells, and it's important to note that this is an intracellular marker that requires permeabilization of the cells in order to see it, rather than most other markers that we examine, which are cell surface markers. We can use flow cytometry also to establish how much DNA is within the cell. And in this case, we identified the fact that these cells have a DNA index of approximately 1.19 or 1.2 times the amount of normal DNA within a cell. As I'll show you in a minute, this is typical of high hyperdiploid ALLs having an increased DNA content. And in fact, the cytogenetics in this case bear out the fact that the child has trisomy 21, and in addition has a high hyperdiploid karyotype, which I'll go into some detail. So let's talk about the cytogenetics that one sees in typical BALL. So the most common chromosomal abnormality is actually high hyperdiploid ALL, defined by 51 to 66 chromosomes. This is about 25% of pediatric ALL, and it corresponds to a DNA index of greater than 1.16 DNA content. It's typical that one gains chromosomes 4, 10, 14, 17, 21, and chromosome X, whereas the so-called good prognostic trisomies were 4, 10, and 17, and now we regard as chromosomes 4 and 10 as having a particularly good prognosis. The most common simple translocation that we see in pediatric BALL is the TEL-AML1 or ETV6-RUNX1 translocation, which is detected in about 25% of cases, but it's very important to note that this is cytogenetically cryptic, and it needs to be assayed by fluorescence in situ hybridization or by RT-PCR. It's often associated with the deletion of 12p on the other copy of TEL, which can often be a clue to the diagnosis. Other phenotypically characteristic ALL cytogenetics include the T514, in which the patients have profound eosinophilia, which is a reactive eosinophilia. The T119 E2A PBX1 or TCF3 PBX1 translocation is often associated with ALL in older children and was once thought to have a poorer prognosis. And unlike this child who had Down syndrome ALL, most patients with Down syndrome and ALL have a normal apparent karyotype, but when we interrogate using FISH or other methods, they often have cryptic translocations of CRLF2 on the pseudoautosomal region of the sex chromosomes. Moving on to more and somewhat rarer BALL cytogenetics that tend to be bad actors, we include MLL rearranged leukemia. This is the most common ALL cytogenetics in infants. It involves chromosome 11q23 and multiple partners. It can be cryptic and requires FISH to confirm. Philadelphia positive or BCR-ABL positive ALL with a 922 is seen in a very small fraction of pediatric ALL, but is increasingly common with age such that it constitutes nearly 50% of adult ALL. It's important to note that the karyotype does not tell you what the specific translocation is, whether it involves a protein predicted to encode protein of 190 kilodaltons, which is typical of de novo ALL, versus an RT-PCR product predicted to encode a product of 210 kilodaltons that's typical of CML and CML, or chronic myeloid leukemia and blast crisis. Hypodiploid ALL is ALL defined as having fewer than 45 chromosomes. This has a very poor prognosis, particularly when associated with low hypodiploidy, that is 32 to 39 chromosomes, which itself is highly associated with germline p53 mutations in the pediatric age group. Another subgroup of another group of ALLs that have fewer than the normal complement of chromosomes is near haploid ALL, which doesn't have quite such a poor prognosis as hypodiploid ALL. Increasingly, we are recognizing a group of BALLs that behave in a manner that's very similar to BCR-ABL-like BALL. This includes the Philadelphia-like BALLs, which typically involve ABL class tyrosine kinases such as the EPO receptor or CRLF2, often translocated to an immunoglobulin enhancer. These often have secondary mutations in the JAK proteins or IKZF2 or Icaros deletions, which themselves can actually be a separate set of poor prognosis AL. By virtue of doing fluorescence in situ hybridization for RUNX1, we've also discovered a new group of ALLs in which the RUNX1 gene is amplified in 5 or more copies in a tandem fashion. This can be identified really truly only by FISH. MYC, which I'll remind you is commonly translocated in Burkitt leukemia or L3 leukemia, is a completely other disease, but it can rarely be seen as an adverse prognostic translocation in TALL. Speaking of Burkitt leukemia, here is a case of a marrow from a child with Burkitt leukemia. You can appreciate that the cells are intermediate sized blasts. They're somewhat larger than neutrophils. They have mature appearing lymphoid chromatin, often with multiple, often peripherally placed nucleoli. They have this deeply basophilic cornflower blue appearing cytoplasm, often that has these cytoplasmic vacuoles that would be fat if one were to stain for fat. By flow cytometry, these are mature B cell neoplasms. They uniformly express CD19 and CD20, as well as other B lineage markers. They're essentially uniformly positive for the common ALL antigen CD10. But unlike lymphoblastic leukemia, they're positive for surface light chains, surface heavy chains, surface light chains, and are negative for terminal deoxynucleotidal transferase. So to recapitulate the morphology, Burkitt lymphoma and leukemia have a similar morphology. These are intermediate-sized lymphoid cells with mature chromatin, basophilic cytoplasm, and vacuolization. And as we'll discuss with T lymphoblastic leukemia, lymphoma, it's really a semantic distinction between whether a tumor is lymphoma or leukemia, depending upon the extent of marrow involvement, often required by certain protocols. The immunophenotype, as I said, is a mature B cell that expresses B lineage markers, clonal surface immunoglobulin, kappa or lambda light chains. It's negative for immaturity markers like CD34 and TDT. And as I said before, it's important to make the distinction that CD10 positive neoplasms are not all lymphoblastic leukemia. They may be Burkitt lymphoma with a leukemic phase. It's defined by a rearrangement of the MYC oncogene, which brings the MYC oncogene in proximity to an Ig enhancer, either a heavy chain locus on chromosome 14 or a light chain locus on chromosome 22 or chromosome 8. Sometimes there's a deletion of 11q in those cases that are MYC negative that has a Burkitt-like morphology. Our next case is a 12-year-old boy with a white count of 86,000 in an anterior mediastinal mass. Here is a preteen boy with a very high white count and a mediastinal mass. It's really quacking like a duck. Morphologically, these cells are the morphologic features of lymphoblasts. One cannot distinguish T lymphoblasts from B lymphoblasts morphologically. By flow cytometry, these cells have an abnormal T cell phenotype where they express the canonical T cell markers 2, CD5, and CD7. This particular case lacks the sublineage markers CD4 and 8 and is positive for cytoplasmic CD3. It's very common for CD3 to not be expressed on the surface, but to be expressed in the cytoplasm of T lymphoblastic leukemia. This case makes the point that the common ALL antigen CD10 can also be seen in TALL. This case had a normal karyotype, which is often the case, but by FISH showed a chromosome 9p CDKN2A deletion, which is particularly common in TALL, but carries no prognostic significance. As I said, with Burkitt lymphoma and leukemia, the distinction between leukemia and lymphoma is semantic. Often leukemia is defined as having greater than 25% marrow involvement. Unlike in BALL, except in certain cases, TALL is commonly associated with translocations between the T cell receptor loci, more like B cell lymphomas, and other oncogenes that are involved in normal hematopoietic differentiation, including HOX and HOX-like genes, as well as many other transcription factors, including TAL1, many of which are cryptic to cytogenetics. As I said, deletion of chromosome 9p in the CDKN2A locus is common. Here's another case. This case is somewhat more difficult. These are larger blasts. They have ample basophilic cytoplasm, pretty fine chromatin, and large punched out nucleoli that make me think about AML. But in this case, we see a peculiar phenotype in which the cells express a CD7 positive phenotype, but they're negative for CD5. They're negative for surface CD3, but in addition, they co-express HLA-DR, which is not true of most cases of TALL, CD117, which, as I told you, is a myeloid immaturity marker typically. They're also positive for CD34 and TDT. These cells are negative for CD1A, but they do express cytoplasmic CD3, which is a defining quality of TALL. In addition, they express another myeloid marker. So here in this case, we sort of have a crazy mixed up T and myeloid phenotype, which makes the point that T lymphoblastic leukemia lymphoma immunophenotypes often have aberrant T cell expression, T lineage markers, such that they've lost one or another T cell marker and have gained CD10, which typically isn't expressed on many T lymphocytes. But in other cases, one also sees a phenotype that's sort of a hybrid between a myeloid and a T lymphoid phenotype. This phenotype we've come to regard as an early T precursor phenotype. It was originally defined by a gene expression pattern, but an immunophenotype is a surrogate. And the surrogate immunophenotype is a TALL that's CD1A negative, CD10 negative, CD8 negative, CD5 weak or negative. And it's often typically positive for one or more stem or myeloid markers, including CD117, CD34, HLA-DR, and other myeloid markers. However, unlike a mixed phenotype leukemia, these cells should not be positive for myeloperoxidase. Moving on to acute myeloid leukemia, our first case is a 16-year-old girl with pancytopenia and peripheral blasts. You can appreciate in the low power view that she has a few cells, some of which look like neutrophils, but others of which have this deeply purple cytoplasm, which one can likely appreciate that these are multiple hour rods stacked up together. In addition, the nuclear contours of many of these cells appears sort of bilobed. If one looks at the marrow from this patient, one sees similar cells to those. Occasional cells have hour rods, which is a defining characteristic of myeloid leukemia. They have an ample blue cytoplasm and this sort of cleaved looking sort of bilobed nucleus. This is a permutation on a theme. Another patient with the same disease with a slightly different morphology is shown in the following, which is more classic and easier to recognize, the dysplastic promyelocytes of acute promyelocytic leukemia. So in both of these cases, the flow cytometry can be similar. Some differences do occur. These cells are CD45 dim positive cells. They're typically negative for HLA-DR. There are 3 leukemias that are commonly HLA-DR negative. They include TALL, megakaryoblast leukemia, and acute promyelocytic leukemia. So whenever you see an HLA-DR leukemia, consider that differential diagnosis. APL is typically CD34 negative. It's always CD117 positive, expresses a number of myeloid markers. But even if it does not have the characteristic hypergranular morphology, they will have strong myeloperoxidase staining. Of course, acute promyelocytic leukemia is defined by the PML-RAR alpha 1517 translocation, which is sensitive to all retinoic acid. Some variant translocations do exist, and for that reason, if something looks like APL, something other than RT-PCR or a come-together FISH probe should be used. I've made the distinction between the hypergranular variant, where they're hypergranular dysplastic promyelocytes, often with multiple hour rods, with the classic HLA-DR phenotype. But of course, this disease is tricky. The microgranular variant phenotype has these bilobed blasts, often with submicroscopic granules, but is yet very strongly MPO positive and can be HLA-DR and CD34 positive. So your index of suspicion has to be high for a patient with microgranular variant. Patients with microgranular variant APL typically present with very high white counts, whereas those with hypergranular variant often present with lower white counts. Our next patient is a 16-year-old boy who appears to be relapsing post-transplant for AML. Here's his bone marrow. You can appreciate that his bone marrow has relatively few blasts. Here I see a lot of cells that look like monocytes and immature monocytes, sort of a monoblast, myelomonoblast to me here. There's also a lot of eosinophils here. And if one looks carefully, one can appreciate that there are cells that look like crazy mixed up eosinophils that have basophilic granules, so-called eobazos. If one looks like by flow cytometry, one can appreciate that there is indeed a population of myeloblasts that express CD34 and 117, as well as other myeloid markers. And the karyotype in this patient has an inversion 16. And by FISH, this involves the CBF beta and MYH11 gene and defines acute myelomonocytic leukemia with an inversion 16, the old FAB-M4EO. Before I discuss that case, I want to go on to another case. Here's an 11-year-old girl with leukocytosis, anemia, and thrombocytopenia. And this is the cell-o-vision view, so the sort of snapshots of individual cells in her peripheral blood. Here, I actually don't see any classic blast, maybe something getting toward a classic blast. Most of the cells look like immature dysplastic granulocytes in a variety of different stages of differentiation. Here's the marrow from this patient, which is actually as sort of subtly abnormal, but not terribly abnormal. You can see there's dysplastic appearing granulocytes. There's immaturity here. Perhaps there's a blast here. Maybe there's a blast here, and maybe there's an hour rod there. There's some cells that have these sort of distinctive salmon pink granules. By flow cytometry, these are myeloblasts that express CD117 and CD33. They're strongly myeloperoxidase positive, and yet they also co-express the lymphoid marker CD19, the B lymphoid marker CD19, and they're often equivocally positive for TDT. So is this a mixed phenotype leukemia? No, this is one of those leukemias where we accept as having a mixed phenotype is really a defining factor. So to summarize here, we have a marrow that has less than the 20% blast required for a diagnosis of AML, with maturation that's dysplastic, a myeloid phenotype that co-expresses CD19. And what makes the diagnosis is a translocation involving chromosomes 8 and 21, which is positive for an ETO AML1 or RUNX1, RUNX1T1 in 65% of cells. So this is an acute myeloid leukemia with a recurrent cytogenetic abnormality 821 that used to be classified as FAB-M2 AML. These last two cases that I showed you are examples of core binding factor AMLs. The first being being the inversion 16. The inversion 16 isn't always an inversion. Sometimes it's a translocation between the two copies of chromosome 16. And like other translocations, it can often be cryptic, and it really requires FISH to prospectively look for the translocation. The 821 RUNX1, RUNXT1 translocation is the most common cytogenetic abnormality that we'll see in non-infant AML in pediatrics. And it's important to make the point that certain diseases, these two in particular, are defined by their cytogenetics or molecular alterations and not by a morphological feature such as the percentage of blasts in the bone marrow. Let's move on to infants with leukemia. First case is an infant female with a white count of 100,000. We have blasts here that have a lymphoid morphology. Once again, they're maybe twice the size of red cells, somewhat mature, somewhat streaky chromatin with small indistinct nuclei, scant cytoplasm. In this case, many of the cells have a distinctive cleave, which is often characteristic of this particular disorder. By flow cytometry, these are B cells that are dim for CD45. And they're positive for CD34, which is immaturity marker. But unlike most BALLs, they're negative for CD10. And in addition, they had a slight whiff of CD15, which is a myeloid marker. So here we have a BALL that is CALA negative and showing some myeloid marker positivity. And this phenotype is actually typical of infant ALLs associated with MLL translocations. And in this case, we saw an MLL AF4 translocation, the T411, which is the most common cytogenetic abnormality in infant ALL. The next patient is an infant female with the same white count, but this one has multiple non-tender violaceous skin nodules. Here we have very large blasts that are huge, 4 or 5 times the size of a neutrophil. Some of them have elongated, perhaps a little bit folded nuclei. They have ample agranular or perhaps paucigranular cytoplasm. No hour rods are evident. And in general, they remind me of immature monocytes, particularly a cell like that. By flow cytometry, these cells are positive for CD117, making them of myeloid lineage. They don't express the immaturity marker CD34, but they do uniformly express a marker of monocytes such as CD64 and CD65. And they are not positive for myeloperoxidase. In this case, the karyotype came back with a balanced translocation between 6 and 13, an inversion of 10, but that didn't belie the entire story, as FISH was also positive for an MLL or mixed lineage leukemia translocation located at chromosome 11q23. So this is a case of acute monoblastic leukemia. They're large blasts, non-specific esterase positive, often involving the skin. These are the patients who will often be CNS positive or have involvement of other extramedullary sites. MLL translocations are common, not only in ALL, but also in AML, particularly infants. There are innumerable translocation partners. As this case demonstrated, it's often not identifiable by karyotype. And once again, this can be seen in a wide range of leukemias, not just AML and ALL, but also by phenotypic leukemias, as well as therapy-related leukemias that can either be acute myeloid leukemia and much less commonly acute lymphoid leukemia. The next case is a 30-week preterm female with high drops in a common atrioventricular canal. Their white count is notable for a very high white count with a large number of nucleated red cells, a relatively preserved but still decreased hemoglobin, a preserved platelet count, a slight a coagulopathy, and a high tumor lysis labs. Here's some snapshots of the peripheral blood. The red cell morphology is kind of crazy, like you see in many babies. In addition to nucleated red cells here, you can see that there are these big blue blasts that are agranular. Some of them have nucleoli. They have somewhat streaky, more mature, maybe lymphoid-looking chromatin. By flow cytometry, however, these cells are CD45 dimmed, demonstrating their immaturity. They express CD117, the myeloid immature marker, as well as CD34. They're positive for CD61 and CD41, which are megakaryocytic markers, as well as multiple other myeloid markers. They are HLA-DR negative, and they also express two markers that we think of as being expressed in T cells, but are also expressed in immature megakaryocytes. This is being CD4 and CD7. So this is a case of a child with Down syndrome and so-called transient abnormal myelopoiesis, the myeloproliferative disorder of Down syndrome associated myeloproliferative disorder, transient myeloproliferative disorder, or whatever its name happens to change to this week. These are disorders of a megakaryoblast proliferation, often with sort of erythroid kind of qualities to it, occurring prior to or within days of birth. I like to refer to the blasts as big, blue, and blebby, or the 4 Bs. They have this canonical recurrent immunophenotype that I recite here, which is one of those HLA-DR negative cases of acute leukemia. They're invariantly associated with trisomy 21. That's typically a germline, but can be a chimeric trisomy 21. And they've acquired somatic GATA1 mutations that in exon 2 that result in the truncated form of GATA1 being preferentially expressed. About 20 to 30% of these individuals will go on to frank acute megakaryoblast leukemia, which has the same immunophenotype. These patients are typically less than 30 months of age, but one often sees acquisition of secondary chromosomal abnormalities, as well as a variety of characteristic secondary somatic mutations, including cohesin components and epigenetic regulators. The phenotype is completely indistinguishable from the transient process. The next infant is an infant with pancytopenia and teardrop red cells, suggesting something like marrow replacement. Here are the blasts in this case. They're not huge blasts. They're kind of lymphoblast in size. They kind of have lymphoid chromatin. Some of them have bigger nucleoli, but many of them seem to be shedding off these things, some of which are often looking like platelets in the peripheral blood. By flow cytometry, these cells are also positive for CD61 and CD41, as well as the myeloid marker CD117 and other myeloid markers, including CD13 and 33. So this expresses the canonical megakaryoblast markers. This patient does not have Down syndrome. Here's the bone marrow biopsy, which is not blue, but rather kind of pink, which demonstrates that there's really extensive fibrosis in this bone marrow. This is a very characteristic clinical presentation of myelofibrosis that can often be quote unquote acute in an infant. So this is a megakaryoblast leukemia with a T122. It's a very unusual tumor, but it's very distinctive, and it occurs only in infants and in those infants without Down syndrome. The next patient is a little bit of a different theme. It's also an infant, but this patient presented as an infant, but is now 18 months of age. They're non-dysmorphic. They happen to have a heart murmur. They're otherwise well. They have a high white count. There's mostly neutrophils with an absolute monocytosis, a high eosinophil count, and some immature cells, including promyelocytes and nucleated red cells. Here's the low power morphology. You can probably, even from low power, appreciate the fact that there's a lot of neutrophils as well as cells that look like they could be immature, monocytes perhaps. There appears to be thrombocytopenia. We're told that the patient has anemia. We go under higher power. The neutrophils don't look quite right. Here's a neutrophil that has no granules. Here's a neutrophil that seems to have too many lobes. Here's something that's more immature, like a myelocyte. Here's maybe a metamyelocyte. And then we have this immature monocyte in the peripheral blood. We get additional data from this patient. The patient has a hemoglobin F that's relatively increased for age, a normal bone marrow karyotype. FISH is negative for monosomy 7, trisomy 8, and a partial deletion of 7q. And next generation sequencing shows that the patient has a RAS-MAP kinase pathway mutation, specifically a somatic mutation in PTPN11, which is, of course, the most common molecular genetic abnormality that we see in patients with juvenile myelomonocytic leukemia. The diagnosis of juvenile myelomonocytic leukemia is evolving. It used to be a diagnosis based upon a series of select 2 from this category, 1 from that category. Now it's substantially been supplanted by the detection of RAS-MAP kinase mutations in patients with otherwise typical clinical features. The next patient, on a theme moving away from infants, is a 16-year-old male with a history of digital warts and an episode of atypical mycobacterial lymphadenitis, now with pancytopenia. Marrow is hypercellular. You can appreciate that even from this power that there's some megakaryocytes that don't look quite right. This marrow doesn't really comport with a pancytopenia, suggesting that there's ineffective hematopoiesis. You can appreciate these megakaryocytes with separate nuclear lobes, as well as neutrophils that don't have a normal lobation pattern. A CD34 stain shows that the blast count is not grossly increased above 5%. So here we have a hypercellular marrow with multilineage dysplasia, blast not more than 5%. The cytogenetics came back with a monosomy 7, and the genetics on a next generation sequencing panel show a GATA2 germline mutation. So a teenager with monosomy 7 associated MDS or AML, think about GATA2. That's the population that monosomy GATA2 germline mutation carriers. So myelodysplastic syndromes, while uncommon in children, commonly present in adults. These are clonal hematic disorders characterized by cytopenias, dysplasia, and recurrent genetic abnormalities. The MDS categories listed in the WHO classification aren't highly relevant to pediatrics, since many of the MDSs that we see in kids are those associated with germline predispositions to MDS and AML, some of which have pre-existing organ dysfunction or thrombocytopenia. And I encourage you to review the entire list here. The next to last patient is a 19-year-old female with recent fatigue and a 5-pound weight loss. She had her wisdom teeth taken out. She had difficulty with bleeding and was discovered to have a white count of 469,000, was anemic, and had a very high platelet count, although it seemed to suggest that she had dysfunctional mucosal bleeding. A bone marrow aspirate and biopsy were performed, which shows a hypercellular marrow with a marked relative myeloid hyperplasia with numerous basophils, as well as a left shift. One can appreciate many dysplastic appearing megakaryocytes, as well as storage histiocytes, so-called C-blue histiocytes. The biopsy is hypercellular and shows you that a large number of eosinophils. Of course, this patient has chronic myeloid leukemia with a translocation 922, FISH positive for BCR-ABL, and RT-PCR positivity for P210. So this is chronic myeloid leukemia, which is emblematic of the chronic myeloid neoplasms, which are clonal stem cell disorders. They're characterized CML by a neutrophilic leukocytosis with a left shift, often with basophilia and eosinophilia. thrombocytosis, sometimes with platelet dysfunction, and CML is defined by a BCR-ABL translocation. It can evolve to blast crisis, which in children, unlike adults, is most often BALL. But it's important to note that we also do see adult-type myeloproliferative neoplasms, including polycythemia vera and essential thrombocytosis, which themselves are associated with tyrosine kinase pathway mutations. And the last case that I'm going to show you today will keep you thinking. Things aren't always what they seem. This is a 9-year-old boy with pancytopenia, bone pain, and that proverbial diffuse marrow signal abnormality by MR. Here's his peripheral blood. It shows these big basophilic blasty looking cells, some of which with the cytoplasmic vacuoles. Here they are on the aspirate smear. Relatively large cells compared to a neutrophil, but not enormous. Perhaps they're a bit cohesive with one another, and one looks at the biopsy, they really do look quite cohesive with opening of the marrow sinuses. Here they are under higher power where they really appear to stream together. And then when we do immunohistochemistry, these cells are positive for the muscle markers desmin and myogenin. And by the cytogenetics, there's a FOXO1 translocation. So in this case, this is a solid tumor presenting with a leukemic phenotype. So this is leukemic alveolar rhabdomyosarcoma, which is something to keep in mind that not all patients with occupied bone marrows have primary bone marrow disorders. So with that, I'll close and thank you and welcome any comments.